Chapter 15 is Medical Overview. The National EMS Education Standard Competencies for this chapter: Medicine. Medicine applies fundamental knowledge to provide basic emergency care and transportation based on assessment findings for an acutely ill patient. Medical Overview will cover assessment and management of a medical complaint, which is very important. It will cover pathophysiology, assessment, and management of medical complaints to include transport mode and destination decisions. The chapter will also look at infectious diseases, with a specific focus on awareness of a patient who may have an infectious disease, assessment and management of a patient who may have an infectious disease. And that's going to come at the end of the chapter. Introduction. Patients who need EMS assistance generally have experienced a medical emergency, a trauma emergency, or a combination of both. Trauma emergencies involve injuries resulting from physical forces applied to the body. Medical emergencies involve illnesses or conditions caused by disease. Now, type of medical emergencies that we will cover in the entire medical module: respiratory emergencies, patients have trouble breathing, or the amount of oxygen supplied to the tissues is inadequate. Cardiovascular emergencies caused by conditions affecting the circulatory system. Neurologic emergencies, this will involve the brain. Gastrointestinal conditions, which would include appendicitis, diverticulitis, pancreatitis, and many others. All of the itis is usually gastrointestinal region. We will look at urologic emergencies, example, kidney stones. We'll go into details with that when we come across that chapter. Endocrine emergencies, most commonly caused by complications of diabetes mellitus. So we look at emergencies associated with the abnormal findings of the blood sugar or the body's inability to utilize insulin. Hematologic emergencies may be the result of sickle cell disease or blood clotting disorders. So when we look at hematologic emergencies, we're going to look at bleeding disorders and clotting disorders. We'll look at immunologic emergencies. This will involve the body's response to a foreign substance. So we're talking about allergic reactions, mild, moderate, severe. Toxicology emergencies will include poisoning and substance abuse. Toxicology is the reverse of pharmacology. So it's abnormal pharmacology, as I like to refer to it. Some medical emergencies are caused by psychological or behavioral problems. That's psychiatric emergencies. Gynecologic emergencies will involve female reproductive organs. That's all the emergencies or all the chapters that we will cover in the medical module. And there's a table that you can look at in your textbook or on your PowerPoint. Now, patient assessment. And this might be the most important aspect of the chapter, the patient assessment. Patient assessment is similar to the assessment of a trauma patient, but with a different focus. So the assessment is going to be the same that you would use for a trauma patient. However, there are some subtle differences. For medical patients, it's very important that you're able to obtain a proper history of the presenting problem. So focus on the nature of illness. This is the chief complaint. Why was EMS activated? Why did this person call for an ambulance? Focus on the symptoms. And remember your difference between your signs and your symptoms. A sign is basically what you can see, smell, hear, and what can be measured. The symptoms is what the patient tell you or complain of, and of course the chief complaint. Establish an accurate medical history. Use dispatch information to guide initial response. Do not get locked into a preconceived idea of the patient's condition. Now, with medical patients, the patient can have typical presentations and they can have atypical presentations. So your understanding of pathophysiology is going to be very important. You need to know the pathophysiology of the problem. Assessment may be difficult with uncooperative or hostile patients. Maintain a professional, calm, non-judgmental demeanor. Refrain from labeling patients. A frequent caller may have different complaints this time. Now, let's start with the scene size up. So, scene size up. Ensure that your scene is safe. Make certain that the scene is safe. Use standard precautions. Determine the number of patients, whether or not you need additional resources or help. Consider the nature of illness. And you're going to think about the index of suspicion. And this is your awareness of potentially serious underlying injuries or illness. So in other words, your index of suspicion is the worst thing you think might be occurring based on the patient presentation. When you do your hands-on assessment, you will eventually find what the issue is, or you may not. After your scene size up, so again, we ensure that the scene is safe. We take standard precautions for ourselves and our teammates. You identify the nature of illness. What is the chief complaint? Determine how many patients you have present and whether or not you need additional resources. You need ALS, request ALS from early. After you've completed your scene size up, the next phase of your assessment is your primary assessment. And in your primary assessment, first thing you do is form a general impression of the patient and the environment. So you consider the patient's age, not their actual age, developmental age, gender, race, level of distress, position that you find them in, whether or not there is any life-threatening issues present. So develop a general impression. Perform a rapid examination of the patient. Quickly determine the patient's level of consciousness. So after you have formed your general impression, the next step is to ascertain the patient's LOC, or level of consciousness, using your AVPU acronym. Now, after you've ascertained the patient's level of consciousness, the next phase of your primary assessment is you're going to assess upper airway and you will assess breathing. And breathing incorporates three things. So three things must be assessed in breathing: patient's ventilation, oxygenation, and respiration. In conscious patients, ensure that the airway is open and they are breathing adequately. Check the respiratory rate, rhythm, quality, and depth. Consider applying oxygen if breathing has been affected. For unconscious patients, make sure to open the airway using proper technique. Do you have a question, Miss Bingham? You keep raising your hand. No questions during my lectures. Questions after.
Sorry, that was accident.
For unconscious, where was I? Check rate, rhythm, quality, and depth. Consider applying oxygen if breathing has been affected. So based on your findings, after assessing rate, rhythm, quality, and depth, you will choose the most appropriate intervention, whether it's supplemental O2 or positive pressure O2. For unconscious patients, make sure to open the airway using proper technique. Apply oxygen to patients who show signs of shock, who present with difficulty breathing when low oxygen saturations are measured. Now, with your low oxygen saturation, because we don't treat numbers, the patient presentation must also indicate that there is an oxygen deficiency. We don't treat a pulse ox, we treat the patient, and we use the pulse ox as a guide. Unconscious patients may need airway adjuncts and ventilatory assistance with a bag mask device. After we have assessed and managed upper and lower airway, and after we have assessed and managed breathing, which is ventilation, oxygenation, and respiration, the next phase is circulation. In a conscious patient, we will check the radial pulse. If the well, not necessarily, yeah. We will check the radial pulse if the patient is responsive. If the patient is not communicating, then you go to your central pulse, which is the carotid. So we'll be checking the pulse. We'll be looking at the patient's skin color, temperature, and condition. We will also consider bleeding for medical patients because a medical patient can bleed as well. For unconscious patients, assess circulation at the carotid artery. And with the pulse, we want the rate, rhythm, and strength. After we have completed our ABCs, at this point, you should know what your patient's GCS is. So you should have a GCS value. You should know if you need to do a rapid scan or a focus, and you should know if you have a patient that requires immediate transport or you can stay and play with this patient. So you need to make a transport decision. Patients in need of rapid transport. Any patient that is unstable is going to require rapid transport. Any patient in which you cannot fix the problem in the field will require rapid transport. So unconscious or have an altered mental status, airway or breathing problems, obvious circulation problems such as severe bleeding or signs of shock. After we have determined if we need to do immediate transport or stay and play, Once you package the patient and put the patient in the back of your unit, if it's a patient that is communicating to you, then you want to ask questions, then obtain your vital signs. So if the person is talking, you ask questions, get your vital signs after. Person not talking, vital signs come before. Look at your physical findings and think about who else can give you information on the scene. So history taking. Determine what the problem is or what may be causing the problem. Get a thorough history. History taking is very important to medical patients. Not saying that you're not supposed to do it in your trauma patients, but it is extremely important to a patient that is having a medical emergencies. Your ability to gather information is important. For an unconscious patient, survey the scene for medications, containers, or medical devices. So again, if the patient can communicate, you communicate with the patient. Then consider your vital signs. Patient can't communicate, look at your physical findings, do your vital signs, think about who else can give you information on the scene or what were the clues present on this location. Very important. Now, if you have a patient that cannot give you clear information, or bystanders or family members cannot give you clear information, when you're doing your vital signs, ensure you check the patient's pupil response, ensure you pay attention to the patient's pulse oximetry, and try and obtain or ensure you obtain a blood sugar reading. This will be very important to those patients. So make sure you include that in your vital signs. You can't get any info. So you will obtain a sample history and use the OPQRST mnemonic. The sample history is broad. The OPQRST focus on the presenting problem. So that's the purpose of the OPQRST. It's going to focus more on the signs and symptoms of that the patient is complaining of, but the sample is broad. So the S is the signs and symptoms. A is for allergies, and your M is medication, P pertinent past medical history, L last oral intake, E events leading up to. The OPQRST is specific to the patient's signs and symptoms. So you're going to look at the presenting problem and you're looking at the onset, what makes it better, what makes it worse, the quality, whether it radiates, the severity, and the consistency. That's the OPQRST. Now, not every medical condition will utilize the OPQRST. All the letters, I should say. Not every medical condition is going to require you to ask all of the letters of the OPQRST. Definitely, if your patient is complaining of pain, you will ask all the letters. But for certain conditions, is certain aspects of the OPQRST, you will ask. So when you're going through your medical emergencies and you get to this point of the chapter, you need to know, look at the medical emergency and say, okay, what would be appropriate for me to ask? Do I need to ask onset? Would what make it better or worse be important? Would the quality be important? Would radiation be important? I need to start document that for each medical emergencies. record any allergies, medical conditions, and medications, and know when to follow up. So don't just run through it because you're swatting the information. Know when to ask follow-up questions. So you ask a patient if they're on medication and they say yes. Don't move on to pertinent past medical history. The patient said yes, I am on medication. Okay, which medication are you on? What do you take this medication for? Is it available? Can I look at it? When was the last time you took this medication? Did it help? Then you move on to your pertinent past medical history. So know when to follow. Very important. Some patients take numerous medications and some take the medication, numerous medication, take the medications with you to the hospital. That's going to be common with your geriatric patients. Now, if a patient has a lot of medication, write down the name of these medications. Do not put in your report that the patient has a bag of medications. Write down the name of the medication. This is going to be useful information to the receiving facility. Now, after you have completed your history taking phase, the next phase is a secondary assessment. May occur unseen or en route to the ED. And your secondary assessment can take the place of your rapid scan in your primary. Don't let me confuse you now. So if you assess a patient's airway, breathing, and circulation, provide appropriate treatment, and they are not unstable, you can either do a rapid scan or a focus. And a focus assessment would be indicated if the patient is not unstable. By doing a focus assessment at that point, you have moved your secondary assessment up. So that's what they mean by doing a secondary assessment on the C. If I check the ABCs, ABCs are maybe a little, the patient might be having a little trouble with the ABCs, and we manage that, and the patient is stable, then you can do a secondary assessment on scene. Then package the patient. So it can take the place of that. That's what would come in the focus assessment. It's basically a secondary assessment. So the secondary assessment may occur unseen or en route to the ED. And if it's being done en route to the ED, it means that your patient is unstable. So under no circumstances, you are going to be doing a secondary assessment on the scene for an unstable patient. Once you're doing it en route, your patient is unstable. In some cases, you may not have time. Rarely, we have time to do a detailed head to toe on a critical patient. So it involves physical examination. All conscious patients should undergo a limited or detailed physical examination. For unconscious patients, always perform a secondary assessment of the entire body or head to toe examination. So it's a detailed, systematic head to toe. Physical examination should include examine the head, scalp, and face, examine the neck closely, assess the chest and abdomen, palpate the legs and arms, examine the patient's back. Now, secondary is a secondary assessment can be a focus, or it can be a detailed, systematic head to toe assessment. And the purpose is We're doing this assessment because we were initially focusing on the primary assessment, or things that can kill the patient quickly. So we're doing the secondary assessment to discover issues, serious issues that can develop slowly, or we were not able to look at in a detailed manner because we were focused on live threats. Now, apart from the focus and detailed assessment, the secondary also incorporates recorded vital signs. And as I have been saying over the past couple of weeks, the vital signs that you are obtaining in your secondary assessment is going to be the vital signs that come after treatment. So these are the vital signs after treatment. So your primary assessment is before treatment. Your vital signs is after. So now you can compare, right? You can compare your findings before treatment and after. With that approach, you'll be able to determine if your patient is getting better or getting worse. And based on the findings, you can make the necessary adjustments that are required. So you will obtain your vital signs. Assess the pulse for rate, rhythm, strength. Identify the rate, quality, and regularity of the respirations. Obtain initial blood pressure. Consider obtaining a blood glucose level and pulse oximetry reading, and of course, pupil response, especially if the patient is not communicating. And I've given you a list of your vital signs that you need to be checking for. Use that list as your guide. Now, after the secondary assessment, we have the reassessment phase. So it is performed once the assessment and treatment have been completed. Begins and continues throughout transport. Consider the need for ALS backup. And if you need ALS, don't delay requesting ALS. Reassess interventions, document and communicate findings, and monitor the patient for any changes. And your reassessment is you basically repeating your primary assessment. That's what you're doing. You're repeating your primary. Again, the goal is to identify trends. So we need to determine again, is the patient improving? Is the patient getting worse? What do we need to change? What do we need to downgrade? Now, when you have a patient that is critical, ideally, you want 3 sets of vital signs. If you can't get 3 sets, you should have primary assessment findings and 2 sets of vital signs, right? So ideally, 2 to 3 sets of vitals. That's going to give you a good idea of if your patient is trending up or trending down. Now, management, transportation, and destination. Most medical emergencies require a level of treatment beyond that available in the pre-hospital setting. I would agree. May require advanced testing available in a hospital. May be beyond the scope of the EMT to administer medications to a patient. EMTs can use the AED, or automated external defibrillator. Scene time may be longer for medical patients than for trauma patients. So once you have time to gather information, you gather information for your medical patient. And that is what is going to delay you on a scene. Now, if the patient is critical, we want to load and go. But remember what I said, once you can gather information, get that information. It's going to be important to the patient management. So scene time may be longer for medical patients than for trauma patients. Gather as much information as possible to transmit to the ED. Critical patients always need rapid transport. Now, type of transport. For life-threatening conditions, definitely lights and siren. However, there are certain patients, even if they are critical, you may not be able to use the siren because it can trigger issues. So with your lights and siren, you need to be careful with your patient that is having a heart attack. You need to be careful with your patient that is having an emergency situation because of migraines, severe migraines, because that can the lights and sirens can trigger seizures in those patients. You also need to be careful with the patient that is having a stroke. The patient with a MI, migraine patient, stroke patient, be very, very careful with the use of lights and siren. And I would tell you to consult your medical control. Your medical control might very well tell you to only go with your lights, no siren. Right? So that's for another day though. Not gonna go too deep into that. Now, non-life-threatening conditions. Non-life-threatening condition, consider non-emergency transport. Now, the modes of transport ultimately come in one of two categories. It can be ground transport or it can be air transport. It can be ground transport or it can be air. Now, ground transport, EMS units are generally staffed by EMTs and paramedics. If it's EMTs only, then it's a BLS transport. If it is staffed by paramedics, it can be a paramedic and an EMT, can be an EMT and a paramedic, or it can be two paramedics. Once a paramedic is aboard that unit, it's going to be an ALS response unit. Now for air transport, EMS units are generally staffed by critical care transport professionals and paramedics. It can be a critical care paramedic and a nurse. Critical care nurse can be critical care paramedic and a flight doctor. So it's usually a combination. Now, destination selection. Generally, the closest hospital should be your destination. The closest hospital that have the resources to treat medical emergencies. Sometimes the patient will benefit from going to another hospital capable of handling his or her particular condition. And that is the management phase. Now let's look specifically at infectious diseases. And this is the last part of the chapter. So general assessment principles for infectious diseases. Approach like any other medical patient. Perform a scene size up, take standard precautions, and complete primary assessment. Gather the patient history using OPQRST to elaborate on the patient's chief complaint. General assessment principles continued. Obtain a sample history and a set of baseline vital signs. Ask whether the patient has recently traveled or has come in contact with someone who has traveled. General management principles. Focus on any life-threatening conditions identified in the primary assessment. Be empathetic. Place the patient in a position of comfort. on the stretcher and keep them warm. Use standard precautions. Now, an epidemic, and with the outbreak of COVID over the the last 2 years, I'm sure everybody know the difference between an epidemic and a pandemic. So, an epidemic, new cases of a disease in a human population substantially exceed what is expected. That's an epidemic. A pandemic is a disease outbreak on a global scale. Now, let's look at some of these diseases or viruses. Influenza. Those with chronic medical conditions and compromised immune system, and the very young and the very old are most susceptible to complications of influenza. And we all know that influenza affects the respiratory tract. Transmitted by direct contact with nasal secretions and aerosolized droplets from coughing and sneezing by an infected person or people. For disease that can be passed by the respiratory route, so this is not specific to influenza, any disease that can be passed via the respiratory route, always wear proper PPE, gloves, eye protection, HEPA respiratory mask or N95. And if you're gonna be wearing an N95 or a K95, you can't just take out the mask and put it on. You have to have a mask that has been fit tested and seal tested specifically for you. And the mask has a time span in which it can be used. So these things are important to note. Place a surgical mask on the patients with suspected or confirmed respiratory disease. Annual influenza immunization is important for EMS personnel to protect providers and patients. And if you're gonna work in the States, you have to take the flu vaccine yearly. So every year you have to take a flu vaccine because the virus constantly changes. And for me, every time I take the influenza vaccine, I get sick immediately after I get sick. But I'm good for the rest of the year. Now, herpes simplex. It's a sexually transmitted disease. Common virus strain carried by humans, and there are two types of herpes virus. You have herpes simplex virus 1 and herpes simplex virus 2. Herpes simplex virus 1 is the one that causes oral herpes, and the simplex virus 2 causes genital herpes. So herpes simplex virus 1 is the oral herpes. Herpes simplex virus 2 is the genital. Now, symptomatic infections cause vesicles that appear on the lips or genitals. Can cause more serious illness in susceptible patients. Primary mode of infection is through close personal contact. And it's an incurable disease. It can't be cured. It can only be treated or control the outbreaks, I should say. So the treatment controls the outbreaks, but there is no cure. HIV infection. EMTs face a risk of exposure. No vaccine exists as yet. AIDS can still be fatal. However, with treatment, patients can expect a near normal lifespan. Not easily transmitted in the work setting. Your risk of infection is limited to exposure to an infected patient's blood or body fluids. Many patients with HIV show no symptoms. Always wear proper type gloves. Take great care in handling and disposing of needles. Cover any open wounds. If you think a patient's blood or secretions may have entered your system, seek medical advice and notify your infectious disease officer. No. Hepatitis, which is inflammation, which will or can lead to infection of the liver, can be caused by viruses and toxins. There's no sure way to tell which hepatitis patients are contagious. So we approach all of them as if they are. Vaccinations with hepatitis B vaccine is highly recommended for EMTs, and it's a requirement. So to work in a proper EMS system, you need to have your hepatitis B vaccine. And I think they have a combination now where you can get hepatitis A and B vaccine. So it's one vaccine and you get A and B. Meningitis. Hold on. Can barely see this chart on my end, but it's an important chart to look at. It outlines the various hepatitis B viruses. The hepatitis C is common in persons who abuse drugs using syringes, and it can cause cirrhosis of the liver. Meningitis. This is inflammation of the meningeal covering of the brain or the membrane that covers the brain and the spinal cord. Most forms of meningitis are not contagious, but there is one that is. Take standard precautions, can be treated at the ED with antibiotics. After treating a meningitis patient, contact your employer health representative. And there is meningitis vaccines available. I don't think it's available in Jamaica, but you can definitely get it in the States. Tuberculosis. Most infected patients are well most of the time. So it's a bacteria that affects the lungs, and it can be latent or active. So it can be latent TB, which is a patient that does not show any symptoms, or it can be active TB. That's a patient with symptoms, right? And if it's latent, the person cannot spread the condition or spread the bacteria. If it is active, they can. So it's chronic mycobacterial disease that usually strikes the lungs. Patients who pose the highest risk almost always have a cough, and this is a cough that will be present for 3 weeks or more. They're going to be complaining of fatigue, loss of appetite. They're going to be losing weight. These are key things to be looking for with your TB patients. N95 or HEPA mask is required to stop droplet nuclei. Now, you're required to do a tuberculin skin test as a EMS provider. I think we do that yearly. And if it's positive, you have to do a chest x-ray to ensure that bacteria is not in the lungs. Absolute protection from the tubercle bacillus does not exist. 1/3 of the world's population is infected with tuberculosis. Have a tuberculin skin test regularly. Preventive therapy is almost 100% effective. And if a person has latent TB, even though they can't spread it to anybody else, they're at risk of developing active TB. So if it's latent, they still have to get treatment. Now, whooping cough or pertussis, also referred to as the 100-day cough. So whooping cough, also called pertussis, mostly affects children younger than 6 years. Symptoms include a fever and whoop sound that occurs when inhaling after a coughing attack. So they start out with cold or flu-like symptoms, and then they develop a cough. But the cough is so severe that it empties all of the air in the lungs. So after the coughing fit, they have to draw in breath. They have to take a deep breath after that coughing fit, and it creates a whooping sound. The best way to prevent the exposure is to be vaccinated. So there is a vaccine for it. Place a mask on the patient and yourself. It doesn't necessarily cause major issues in the adult population. It's more serious in the pediatric population, the younger pediatric population. It can cause significant airway problems for them. Methicillin-resistant Staphylococcus aureus, or MRSA. MRSA is a bacterium that causes infection. However, this bacteria is resistant to many antibiotics. In the healthcare setting, MRSA is transmitted from patient to patient by healthcare providers and unwashed hands. So, one of the primary ways to transmit or get this particular um, infection is treating a patient in an area that is not sterile. So not following sterile procedures will lead to this. The other thing that can lead to it is a patient is placed on antibiotics. A patient is placed on antibiotics and the patient stops taking the antibiotics before they should. So they are placed on antibiotics for the issue and they stop taking the antibiotics before the treatment regime finishes and they develop resistance. So that's MRSA. Common in the we call those places again, old age homes. So the old age homes, yeah, definitely common. You'll find it in the hospital setting if they're not using sterile procedures. Now, factors that increase the risk of MRSA: antibiotic therapy, prolonged hospital stays, a stay in an intensive care or burn unit, exposure to an infected patient. MRSA results in soft tissue infections. So that's MRSA. Global health issues now. COVID-19 originated in Wuhan, Hubei province in China, quickly spread, infecting millions, killing hundreds of thousands, controlling the virus, social distance, hand washing. Symptoms include fever, cough, shortness of breath that appear 2 to 14 days after exposure. If you need additional info, you can check out the CDC official website. MERS-CoV, which is also a coronavirus. Middle East Respiratory Syndrome coronavirus. First human case discovered in 2012 in Saudi Arabia. No cure or vaccine for this virus at present. Place a surgical mask on the patient if MERS-CoV is suspected. Ebola. 2014, and Ebola is basically a virus that affects the body's ability to clot. In 2014 outbreak of Ebola virus, there was an outbreak of the Ebola virus in West Africa. Incubation period 6 to 12 days after exposure. Symptoms may not appear for as long as 21 days after infection. Fatality rate can be as high as 70% if treatment in an ICU is not initiated promptly. It does not spread via airborne, it's fluid. Travel medicine. Be aware of travel-acquired infections when assessing a patient who has recently traveled outside of the United States or outside of Jamaica. Patients can present with a variety of symptoms. When you encounter an ill patient with a recent travel history, place a mask on the patient and gather as much info as possible. Important questions to ask, or important questions to ask include: where did you recently travel? Did you receive any vaccinations before your trip? Were you exposed to any infectious diseases? Is there anyone else in your travel party who is sick? What types of food did you eat? What was your source of drinking water? Now, conclusion. Assessment and treatment of medical patients can be challenging and interesting. And it can be challenging because a medical patient can present with typical signs and symptoms, and they can present with atypical signs and symptoms. And I always say to EMTs, medical emergencies define your skills. These are the emergencies that will define your assessment and management skills as an EMT. Trauma is straightforward. I always say that. Trauma is straightforward. Energy is applied to the body. You think about where that energy was applied, for how long, what is underneath. What is underneath? So medical emergencies define your assessment and management skills as a medic. So assessment and treatment of medical patients can be challenging and interesting because of the nature of medical conditions. The condition of a medical patient may not be as apparent as in trauma patient, and treatment may not be as straightforward. Patients sometimes have more than one isolated problem. And that would be the end of the